Hello, I am trying to squeeze out the rest of this lecture here before I go to bed this evening. So here we go, dissociative disorders. Amnesia and dissociative identity disorder is where they have taken this part of anxiety disorders and split them out from the others. And so here we go, looking at amnesia is looking at the definition, inability to recall information, usually that which is traumatic or stressful, and people definitely have that. I have taken care of patients who have had neurological surgery and have gone off to go home after caring for them, and when they come back for their checkup with their doctor, family member would bring them to the unit and say, hey, this is where you were at, and they have no memory of that, no memory of me, no memory of the stay. And I think, that is kind of a traumatic or stressful event, and so we forget parts when we go through things like that. And so there's that part. Now, a fugue is very interesting. A fugue is just what it says there, a sudden unexpected travel away from home or work locale. Patient or person might take on a new identity. Once recovered, they don't remember having been on the fugue. So there are some disputes whether this is really a true issue or not, because lots of times people that have these have actually been running away from a situation in which they're in trouble. Maybe insurance is looking for them, maybe the law is looking for them, and they are not able, to handle that, and they run away and don't remember anything. But then there are people that actually do this, and you might relate to this if you're driving along and you have a lot on your mind and you're getting to a destination, a familiar destination. Maybe you're driving home from school or driving home from work, and all of a sudden you're there, and you don't really recall going off the exit or what have you. That's sort of like this, a fugue state. All of a sudden you're there, you're back in touch with reality, you know who you are, but you don't remember where you've just been. So we have had that sometimes, and there's a lot of, we're distracted by things that are on our mind. But a fugue where people actually forget who they are, travel to another locale, usually far, far away, can't remember anything about themselves, and then when they retrieve that information, they're able to get that back. They don't remember how they got there. Okay, so that's a fugue. Very interesting. They come up in the news every now and then. Somebody who's been had a fugue, and generally they have had somebody looking for them too. So is it the truth? Who knows? And then lastly, dissociative identity disorder, formerly known as multiple personality disorder. This is where somebody who has experienced extraordinary amount of stress, usually very traumatic, usually something along the lines of sexual abuse and or physical abuse that's ongoing, that's relentless, that doesn't give up, and so the person, in order to deal with that, will dissociate, really kind of pull apart from their body, and in some extreme cases become another person, and that's dissociative identity, and that's called an alter. We'll have an alter, so two or more distinct personalities qualifies one for having dissociative identity disorder, and they do have a whole different personality, a whole different way of doing things and mannerisms. They can be different genders, they can be of different ages. All of these alters are a means to cope with the situation that they're dealing with at that time. And there's been some movies about that and books about that are quite interesting. Again, looking at is this really a true diagnosis, or is this somebody just kind of playing? And some providers of care for psychological services believe this is entirely true, and actually some research studies have shown that when somebody's in an altered state, their blood chemistry actually changes. So you can look at that, but then there are research to disprove that, and there are others that don't really believe this is happening and refuse to deal with the alters, and will say things like, I only want to speak to this person, that is the original person, and that's it. So we'll, see what happens with that along the way. In terms, you don't see these patients too much. They're very rare that you see them come up on a unit, but you might see them. Next slide. Okay, going along with this again, remember dissociative identity disorder, there's a severe level of anxiety. The dissociation does feel like they're coming apart. It feels like they are almost out of their body and they can't control it. And nurses, when when the patients are feeling this way, nurses can really help in offering a safe place, sometimes actually placing ice in the hands, or also can refocus them, bring them back in touch with things, and even wrapping up in a blanket snugly will help to get rid of that feeling of falling apart. So those are some things that we can do with that. So looking at the nursing process and dealing with anxiety, first of all, we have to do an assessment. And the Hamilton Anxiety Rating Scale is very good. You can see that in your text. It's also in SimChart, and you want to make sure you're practicing this to get a feel for what those questions are. The other thing is to really look and remember the different levels of anxiety, and know exactly what's going on with those in terms of the person's perception, their behaviors, etc., and identify that level of anxiety. So we're going to assess looking at the behaviors, their perceptions, their thought processes, have a discussion with that patient, maybe use the Hamilton rating scale, and also you put that all together to determine the level of anxiety that this person is exhibiting. Next slide. Then we will determine what level, and we will assign a nursing diagnosis. So looking at some of the different disorders here, let's look at panic or generalized anxiety. And if we look at panic, of course, we're going to give the nursing diagnosis of anxiety, and we're going to qualify that with being panic level. That way we can address the panic level in our goals and our interventions. And if you look just to the right now, we see anxiety level will go from one level to the next. So from panic down to where we really want it. Maybe mild is too great of a goal. At this point, we'll just go down to moderate. Okay, so just move that patient down. When you say that, so your outcome is going to be decreased anxiety, but from what level to what level? You need to specify that. In generalized anxiety disorder, people remember they're consumed with anxiety, ongoing worry. And so what do they feel with this? An extreme sense of powerlessness. Again, just giving these as examples, there are other nursing diagnoses that may apply. What are your outcomes for this in terms of powerlessness? That the patient will be able to increase problem solving or decision making ability. How do you do that? How do you measure that? Well, we want to be specific with that goal and say that the patient will name 3 positive problem solving or identify 3 ways to cope or whatever. You want to identify, measure that. What are you asking? So increasing problem solving or decision making, we want to find out exactly how are we going to measure that and see that the person is achieving that. So be specific with that patient and what they are needing to do, and that they're going to come up with that. They're going to identify 3 ways to solve this problem, whatever we've identified as a problem. Hope that makes sense. You want to be specific. Don't just say increase problem solving, decision making. How are you going to measure that? Find a way to measure it. Phobias, if they're really getting in the line of in the way of people and getting things done, of course we're going to align some nursing diagnoses that fit with that, and that would be fear. That's a good one. And social isolation. Remember, this person who's got phobias may be so preoccupied with those, they isolate themselves. And this, of course, can go with other, look about agoraphobia, social isolation there. Okay, then we could look at our outcomes. Desensitize, especially when we're looking at some of the simple phobias of fear, the ones we talked about, spiders, heights, and etc. We want to desensitize. Do we want to do it rapidly? That's called implosion. Or do we want to do it over time? Systematic desensitization. So the patient will be desensitized. How do you measure that? Again, patient specific. What are you wanting them to be able to deal with and desensitize to? We need to do that. As far as social isolation, the patient or client will exhibit less isolating, tendencies. How do you measure that? What do you want to see? Well, you want to measure it by them maybe stepping out of their house for 5 minutes each day, or getting out into the day room and sitting down at least for one meal a day. We start really slow, we start really easy, measurable, attainable goals. Then we work our way up once they get going with that. And it's always nice to see when a patient comes out from isolation. We want to also give them positive feedback for that. Next slide. All right, some nursing diagnoses and outcomes with some other of the anxiety disorders, OCD. Familiar one might be ineffective individual coping, and altered role performance, and I have in parentheses agoraphobia too. So you just again look and see what applies here. That when somebody is having obsession and compulsion, they are not able to cope, and it really interferes in their life, and others may need to step in and do for them, other family members, and so we have an altered role performance because they need to take on the duties of that person that's unable to do that. The parenthesis says agoraphobia too. This is a good nursing diagnosis for agoraphobia. Okay, the outcomes on the right side list ways of more positive coping strategies. Well, how many ways? Well, let's start low. Let's say 2 ways of more positive coping. And you can do this with your patients. You can say, let's sit down and think about ways in which you can have some more positive coping abilities rather than always when we're preventing you from the ritualistic behavior. Let's think of some ways that you can maybe cut down half of those or what have you, and you work with the patient. You list those as far as numbers so that you can measure them. The other thing here on there says through limit setting, you're going to break the obsessions and compulsion. So you want to go ahead and talk with the patient. Say, let's cut down on some of these things, and let's not allow these things to happen. See if you can reach those goals. So that would be your measurement. Post-traumatic stress disorder might fall with some nursing diagnoses of post-trauma response or dysfunctional grieving. And our outcomes would be, again, through supportive measures, we're going to decrease the anxiety level from whatever it's at, moderate, or not moderate, but severe panic, down to mild to moderate. Again, increasing problem solving and decision making, and again, make it specific to that patient. What kind of problems are you trying to solve, and how many things do you want them to identify in terms of problem solving? Give that number and start low and then move your way up. Next slide. All right, some interventions that go with all of these here. Individual psychotherapy can happen, and that's very good, especially with your anxious patient. Probably, eventually get into some group therapy, but if you have a whole bunch of anxious people in group therapy, it's only going to spread. So you have to kind of do that with some consideration there. Cognitive therapy really helps here, restructuring thoughts. Excellent way to do that. And behavior therapy is going to be used especially with systematic desensitization and implosion therapy in terms of getting rid of those fear phobias. Group and family therapy really do need to involve families in, especially when there's an altered role performance there. And of course, our psychopharmacology, anxiolytics. Remember, anxiolytics are primarily benzodiazepines, benzos, and then we have Buspar, but Buspar is non-addicting, non-tolerant, and it takes some time to work. So what does anxiety look like? It looks like this. And poor little Piglet, he really needs something to help him out there. And if the benzos and Buspar are not able to work for him, we might want to try a cardiac medication, a beta blocker, something that slows down the heart rate. And we have to be very careful about that because we want to measure our parameters before giving that, making sure the heart rate's in a good rhythm and rate. Okay, that does it for these slides.